So good morning, everyone. Welcome to this Health Protection CPD event that's hosted by CHAMPS, the collaborative. This morning's event is a really jam-packed event around antimicrobial resistance, AMR. We've got some fantastic speakers going, and I hope you all have a really fantastic morning. So just by way of introduction, my name's Helen Bromley. I'm the Director of Public Health at Cheshire West and Chester Council, and I'm the lead director for health protection across Cheshire and Merseyside, which keeps me busy, as you can imagine. So just to extend a really warm welcome to colleagues and our guests from across Cheshire and Merseyside this morning. You'll notice, folks, that we've muted your mics for the main event. They'll be enabled when it comes to breakout rooms later on. If you have any questions for the speakers, can you put them in the Q&A section, please? And then we'll pick them up from that section, not the chat, but the Q&A section. So yeah, the chat is for the chat and the Q&A is, funnily enough, for the Q&A. Just pop your comments in the chat though, and we'll keep an eye on those as well. We are recording the session this morning. That'll help share with you later on if you want to refer back to it for anyone who wants to use this session for CPD or help you with that as well. So that's why we've agreed to record it. So I hope you're all okay with that. You're probably used to that by now. Just to note on the aims of the event. So today's event is to learn more about work taking place to combat AMR in Cheshire and Merseyside. It's to look at future opportunities for collaboration to improve the well-being and reduce morbidity and mortality of our most vulnerable residents. It's to discuss next steps that can be taken forward at a Cheshire and Mersey level. So they're the aims. But as a collaborative over the last 2 months, we've done a lot of work. You know, we've continued to work collaboratively on health protection threats. We've supported the system response to ensure robust responses to increasing numbers of measles, and we've continued to develop and deliver our Simple Things campaign. At the moment, measles is in abeyance, touch wood. I hope I'm not tempting fate by saying that, but it could always pop back up at any time, as you know. And the health protection strategic leads and the health protection practitioners have met twice, I think, in person this year. And we found that really, really valuable just to share notes and learn from each other, really, learn from the two groups. And they're kindly hosted by CHAMPS as well. So really good stuff going on in the health protection space. Just a note about CHAMPS Connect and Learn. This is an opportunity to come together to learn something new and connect with colleagues across Cheshire and Merseyside. This allows Cheshire and Merseyside to strengthen our public health collaborative. We are the public health collaborative, so stay engaged, keep joining in, keep making suggestions. We are all in this together. It'll allow Cheshire and Mersey to strengthen that collaborative, as I said, and also all our events will be promoted in the Collaborate newsletter, which comes out every month, which you can sign up for. And if you can't find it, we can put the link in the chat for you there. So moving swiftly on, if that's all right, to our first speaker, I would like to introduce Dr. Will Morton to you. Will is a consultant in health protection at the UK Health Security Agency Northwest. Will is the lead for antimicrobial resistance in the Northwest and for healthcare associated infections, also for research and development. So pretty full-on portfolio there, Will. He also chairs the National AMR Leads Network. So without further ado, I'd like to hand over to Will, if that's okay.
Thanks, Helen. So good morning, everyone. Thank you to the CHAMPS Network for inviting me to speak at this webinar. And today I'm going to be presenting antimicrobial resistance, a public health problem, and how to tackle it. And during this talk, I'll be covering 3 areas. I'll be giving an overview of antimicrobial resistance as a public health problem. We're talking about what can be done to tackle the issue, and then I'll be going into some examples of the work we've done in the Northwest, to tackle AMR with a particular focus on training and antimicrobial stewardship. Next slide, please. So some of these slides are quite detailed and include links to references throughout, so please revisit them after the session if you're interested and like to find out more, but just for ease, here are some of the key resources at the beginning of the presentation. Next slide, please. Right, so antimicrobial resistance, what is it and why is it a public health problem? So I'll try to avoid acronyms where possible during this presentation, but it is a little bit unavoidable on this topic. So AMR stands for antimicrobial resistance. You may hear me say HCAI, which stands for healthcare associated infections, and I might also say BSI, which means bloodstream infections. So antimicrobial resistance arises when the organisms that cause infection evolve ways to survive antimicrobial agents that are used to treat those infections. So this can occur naturally, but the development and spread of resistance are accelerated by the inappropriate use of antimicrobials in both human and animal medicine and also in agriculture. During this presentation, I will be really just focusing on bacterial infections and their resistance to antibiotics. But it is, of course, an issue for fungal and viral infections as well. So a reminder that this isn't just about managing people admitted to hospital with bacterial infection, but without effective antibiotics, cancer treatments, common surgical procedures such as caesarean sections become very high risk. And unfortunately, this problem is going to get worse from where we are now, with reasonable worst case scenario estimates suggesting AMR contributing to 10 million deaths per year globally by 2050, which is due to eclipse a combination of cancer and diabetes. Next slide, please. So antimicrobial resistance when? So AMR isn't a problem of the future, it's a problem now. And indeed, we're already in a pandemic. There are 1.3 million deaths per year attributed to bacterial antimicrobial resistance. Here in the UK, more than 1 in 5, 22% of bacterial infection, bloodstream infections in 2024 were resistant to antibiotics. During that year, during 2024, there were over 20,000 resistant bloodstream infections, which is a 13% increase from where we were before the pandemic in 2019. This equates to around 400 patient episodes per week, so around 5 double-decker buses full of people with antimicrobial resistant infections per week. 7,600 deaths attributable to AMR per year, and around 35,000 deaths associated with AMR per year. So people in the UK are directly affected by drug resistance every single day. And here in the Northwest, I've not updated this, sorry, but so in 2023, there were over 2,500 resistant bloodstream infections. So this isn't something that happens elsewhere in the world, and it isn't something that's happening in 20 years' time. This is happening now and affecting patients in our health service, and our populations and communities. Next slide, please. Right, antimicrobial resistance, a silent pandemic, so often referred to as a silent pandemic due to limited awareness in the public compared with other health threats. So, for example, antimicrobial resistance causes more UK child deaths every year than we saw from the Group A streptococcal outbreak in 22 and 23, which I'm sure many of you remember caused a great deal of hysteria and of course was awful and was covered, had mainstream media coverage. But we're seeing the number of deaths from AMR infections outstrip that in children every year. And it isn't covered in the mainstream media in the same way. When we look at directly attributable deaths, we see the direct impact of AMR on mortality, which you can see there in the black stacked bar. But when we look at the extend that to associated with antimicrobial resistance, we see the true scale of the contribution of AMR on mortality. Next slide, please. So not all antimicrobial resistant infections are healthcare associated, but HCAIs are a key driver of AMR. So HCAIs often prompt empirical prescribing of antibiotics, and usually broad spectrum ones. So that increases selection pressure, giving bacteria more opportunities to develop or acquire resistance. So patients with HCAIs are often already vulnerable. And when infections are caused by resistant organisms, treatment becomes harder, slower, as well as less effective, which of course worsens outcomes. And there is a cost. So the estimated cost of 2.8 billion to the NHS for managing healthcare-associated infections. So that figure is adjusted for inflation. That was an estimate from 2017. So the inflation's been adjusted, but that covers extended hospital stays, additional treatments, diagnostics, staff time, etc., which all affect patient flow and cost. It hasn't been adjusted for the increase in HCIs that we've actually seen, so it will be larger than that 2.8 billion. And healthcare-associated infections accounted for approximately 0.6% of total NHS spending across the UK in 2018, causing almost 1 million lost bed days. So you can see there is a significant interaction with our health system and impact on our health system. Next slide, please. So antimicrobial resistance, again, further interaction impact with the healthcare system. Whilst HCAIs in the English NHS decreased during the pandemic, you can see on this slide, this is unfortunately, there has been a marked increase since 2021, a significant percentage increase compared to the 2012 baseline has been observed across all 6 organisms that are routinely reported into the healthcare associated data capture system. So we can see that the post-pandemic era, the combination of high throughput, complex patients, delayed discharge, staff shortages and reduced surge capacity creates conditions conducive to the transmission of organisms and increased healthcare associated infection risk. And unfortunately, a proportion of those HCAIs will be antimicrobial resistant infections, and we've therefore seen in turn an increase in AMR infections. Next slide, please. Like most public health problems, antimicrobial resistance does not affect everyone equally. We do see inequalities. So examples in England include carbapenemase producing gram-negative bacterial infections, which is shown on the top right. We see double the rate per 100,000 in the decile of greatest socioeconomic deprivation compared with those living in the least socioeconomic deprivation decile. And then we also see this in prescribing. So the bottom left shows antibiotic prescribing rates against a standardised population. The black bars are northwest sub-ICB locations, so think CCG areas, and you'll see that 5 are in the top of our northwest civils that are in the top 10 in England. Next slide, please. Unfortunately, that issue is getting worse. So this time series shows the rate of resistant bacteremia, so bloodstream infections, per 100,000 population in the most and least deprived quintiles this time, not deciles, based on IMD, and the gap between the most and least deprived quintiles. So this rate has increased across all quintiles, but not equally. And the gap between the most and least deprived quintiles has increased year on year since 2021. So we're now seeing a difference, so 43 per 100,000 compared to 29 per 100,000 in the most affluent population areas, which equates to a 47% difference in rates. So we can see that AMR is clearly a public health problem, but what can we do about it? So next slide, please. There we go. So this is a systems map, so don't worry too much about it, but it's this shows the factors that influence on the development of antimicrobial resistance. This includes both understanding the pathways and spread of infection and resistance that could cause increased mortality and morbidity, as well as in identifying interventions that may impact on those pathways. This has been done by identifying reservoirs of infection and the pathways that link these reservoirs. So the reservoir may harbour the infectious agent without any injury to itself and serves as a source from which other individuals can be infected. This highlights really to me that this is a complex and truly global public health problem. Tackling antimicrobial resistance requires coordinated action across society. In the top right-hand corner, you can see, or you may be able to make out the sort of oval in the top right with the red arrows pointing at it. That's human healthcare. So that's the area we have the most influence over. But you can see that really is only actually a small part of the picture. But I will today focus on, of course, that area which we do have influence over. So next slide, please. So fear not, it is very complicated, but in 2019, the UK published a 20-year strategy called Contained and Controlled, which is supported and underpinned by a series of 4 5-year national action plans. We're on the second of those now. These are truly cross-government publications, are very detailed, but the latest national action plan can essentially be broken down into 4 broad areas. So for human healthcare, which is preventing infections, optimizing the use of antibiotics, so stewardship, innovation, so advances and dissemination of technology, so point of care testing, novel antimicrobial agents, and then global action. There are 9 outcomes which summarise the direct impacts of the 24 to 29 National Action Plan intended to have, and 3 of which are supported by human health targets. There's also 30 commitments which set out what action will be undertaken by government organisations to achieve these outcomes, which are all independent deliverables. So a really complex action plan, but also a really good resource, and I would definitely signpost people to that. Next slide, please. So I just wanted to briefly touch on dental. So I just wanted to highlight that within the NAP, the National Action Plan, there is a dental AMR work programme, which is led by Yvonne Daly here in the Northwest. So Yvonne chairs the National Dental Subgroup of SBAR, which is a group that you may have seen publish a report last week called the English Surveillance Programme of Antimicrobial Usage and Resistance. So I'm just sharing these resources on behalf of Yvonne. I'm not an expert in this and I can't really talk to it very well, but please refer back to the slides after the session and do get in touch with Yvonne if you'd like to know more about the work that's going on both regionally and nationally on dental, which is a key component, particularly on prescribing, but also on preventing infections. So next slide, please. So here in the Northwest, UK Health Security Agency Northwest, we always include objectives in our annual work programme. This is a priority area for the organisation nationally, so that translates in a priority for us regionally. We undertake a wide range of activities that support those deliverables in the National Action Plan. Those include system leadership, surveillance and epidemiological investigations, quality improvement, communications and engagement, training and workforce development, which I'll go into in more detail in this presentation today. Next slide, please. So some of our recent work on training and development includes we led a region along with NHS England, and most of this work is in conjunction with NHS England, I should mention that. We held a regional C. difficile seminar in conjunction with NHSC partners, which led to development of a regional action plan in response to CDI rates, increasing C. difficile rates, sorry, and the coordination of a regional response to a national guidance consultation, which is still being worked through, and we are due updated national guidance any time now. We've in the last couple of years delivered eBug trainer sessions across 3 regions. So this is these are educational materials which are designed to be delivered in from early years right the way through to 16 education. Those sessions that we ran were attended by reps from 17 local authorities to cascade and integrate IPC and AMR content into the national curriculum, and that was in response to DCPH requesting activity on AMR. So that was a good opportunity to engage with schools and the young people in our population. We delivered Target, which I'm going to go into in a bit more, so I'll explain the acronym then, but we delivered Target Train the Trainer events across 3 sub-regions. And we supported, so Field Service Northwest, another part of our organisation here in the Northwest, to deliver the healthcare epidemiology training course, which is extremely popular, it's always oversubscribed, and provides NHS clinicians with skills in outbreak investigation and the management of healthcare associated infections. And we've done various other initiatives such as the penicillin allergy delabelling campaign. But so next slide, please. Yeah, that's it. So this afternoon, I wanted to give a bit more detail on our work on antimicrobial stewardship training. So back in 2023, looking at the SBAR report, which is signposted at the beginning, but there's a really great report produced every year if you're not familiar with it, and found that antibiotic prescribing rates, based on defined daily dose, were highest in the Northwest of all regions in the country. And we also had the second highest rates of antibiotic resistance burden in the Northwest. So we were trying to think, what could we do about these two issues? At the time, 80% of antibiotic prescribing was in primary care, with 74% of it in general practice. It's actually gone down a little in general practice since then. And we know from the evidence base that inappropriate prescribing is a key driver of antimicrobial resistance. So how to target primary care prescribers? Next slide, please. Okay. Oh, sorry, the animations are on this. Oh, right, that should just be okay. So the treat antibiotics responsibly guidance, education and tools training initiative has been around for some years. Was developed back in PHE days, and is an evidence-based, and champions use of evidence-based guidance and education and tools for primary care healthcare providers, prescribers, to prevent and manage common infections. And really the key point is that it's to optimize antibiotic use. So it's not just about stopping it completely. It's not stopping about prescribing antibiotics. It's about stewardship and safe prescribing of antimicrobial agents. The target initiative supports IPC, infection prevention control initiatives, how to improve how antimicrobials are used, empowers patients to manage their own infections, preserving antibiotics for future generations, and importantly, all participants, so all clinicians that participate, register on a national database when completing the course, which includes assessment of pre and post training knowledge. This enables the rollout to be tracked, as well as the change in knowledge at individual level. Next slide, please. So worked closely with colleagues at NHS England to roll out the target training across the Northwest. We delivered train the trainer sessions to try and make things as efficient as possible. So in September 2023, we ran 3 whole-day workshops, which were face-to-face, one in each ICB area in the Northwest. And then in February, we had a mop-up online session, which we ran for half a day. We did this for free. Essentially, there's no central funding. We managed to get the venues for free, and all staff time was donated. Sessions were advertised and promoted by ICB, antimicrobial stewardship leads. We had online registration, including a commitment to deliver onward training, and that was key. We only wanted people to attend if they were committed to then delivering training in their own workplace, in their own practice. After completing the train the trainer sessions, participants were invited to an ICB level AMS online forum hosted on Future NHS for peer support and coordination of delivery of onward training activity. The workshops followed a standard agenda where we ran through the train the trainer slides. We delivered the target core training slides, and then each one of these has to have a clinical scenario as part of the training, from a range of 6, which I'll talk about in a minute. And then they had group work to work on their action plan of how they'd then go on and deliver and disseminate the training in their workplaces. So
2 minutes,
next slide,
Will.
please. Yeah, thank you. Next slide. This shows Northwest train. Yeah, that's the one. This one shows Northwest training activity over time. Registered trainers are shown in pink. So you can see the large train the trainer events run by UKHSA and NHSE. Total of 946 trained, at least 100 completed train the trainer sessions, with 23 we weren't able to identify whether they did the training or the train the trainer. So we can see that this is an efficient rollout of our method of delivery, and it persists today. That work that we put into it 2 years ago. Next slide, please. How do we compare nationally? So to date, over 2,400 people have completed target training. Almost 40% of those in the Northwest, which I think we should be proud of. Next slide, please. So this looking at ICB level in the Northwest, across the 3 ICBs, at least 910 people have completed either train the trainer or AMS training, with the highest training rates here in Cheshire and Merseyside, which I'm sure everyone's pleased to hear. And this graph also shows that but it does show that all ICBs in the Northwest has at least one person being trained as a train the trainer approach. Next slide, please. So drilling down lower than ICB level, at PCN level, 62% of PCNs in this region have at least one person who's completed the training, but there is variation between sub-regions. And here in Cheshire and Merseyside, Actually, 96% of PCNs have at least one person who's completed the training, which is something that really should be celebrated. And we're extremely grateful for those colleagues who've gone on and delivered onward training. Next, at practice level, finally, we just see, next slide, please. At practice level, a quarter, or over a quarter, 27% of practices in this region now have at least one person who's received training. And in Cheshire and Merseyside, it's actually over half. So over half of GP practices in Cheshire and Merseyside have someone working there that has completed one form or other of target training, which I think is a wonderful achievement. Probably just going to, next slide, please. Yeah, so we always include a clinical scenario in target training. That's part of the requirements to fulfill the programme. It varies by season what we use. Sore throat is generally the most popular one that's used, and that's we leave that down to clinicians that attend the sessions, but generally sore throat is the one where people struggle the most. Next slide, please. This just shows the impact of knowledge. These are the pre and post knowledge scores, so they do a questionnaire before and after doing the training, and you can see the pink bars there plotting the train, but we could change. But we can see that post-training scores are over 90% across all of those areas around knowledge of the areas that are covered in the training. And then finally, I just want to show some impact. So that's shown the not change in knowledge has been an impact on prescribing. So preliminary analysis shows 3.6%, which is statistically significant, decrease in antibiotic prescribing in primary care in the northwest of England during the period that covered the target rollout. So the dark blue line on the time series shows Cheshire and Merseyside. So of course this is this isn't necessarily cause and effect, but we have demonstrated that there has been a change during that time. And next slide, please. We can also see, so this is quite a busy slide, but if you just focus on the pink lines, the second one along, it shows the northwest. Total NHS and secondary care, so primary and secondary care prescribing and antibiotic consumption is displayed here. We can see that in the northwest there has been a decrease over that 3-year period, particularly looking at the middle line, which shows primary care separated out. So finally, I just wanted to say thank you to all of those who supported delivery of this work. There are many not listed on the screen, including the 946 primary care clinicians who took time to complete the training and then deliver onward training. And we're even more grateful. We're grateful to our cohort of trainers who've gone on and delivered training in their practices, and especially those here in Cheshire and Merseyside. So hopefully this presentation has provided you with an overview of why AMR is an important public health problem at international, national and regional levels. And I also hope that I've managed to give a tangible example of small steps that can be taken at local level, even at individual practice level, towards delivering the commitments and deliverables, thinking back to that really complex 85-page long national action plan. Hopefully this shows an example of what we can do working together. Thank you.
Thanks very much, Will. There's absolutely masses in that conversation and that presentation, which was excellent. So thank you for that. It has generated a few questions as we've gone along, but we're going to pick those up after our next presenter, if that's okay, just in the interest of time and keeping everyone awake with sort of breaking it up a little bit. But thank you for that, Will. I'd like to introduce our next speaker to you now, who is Carrie Barton from Knowsley Place at NHS Cheshire and Merseyside ICB. Carrie is the Head of Medicines Management at Knowsley Place NHS. She's worked in the NHS since 2005, where she started her career as a pharmacist at Wiston Hospital. After 10 years in hospital pharmacy, she moved to St Helens CCG, where her interest in ensuring antimicrobial prescribing started. In 2018, Carrie moved to Knowsley CCG as the Quality and Safety Pharmacist, where she led on the AMR agenda for Knowsley, achieving positive reductions for inappropriate prescribing of antibiotics in primary care. Carrie is currently the lead for AMR across NHS Cheshire and Merseyside, bringing the system together to ensure a high standard of care to our patients, our residents, and targeted prescriber support where necessary. So, Carrie, I'd like to hand over to you now and take it away. Thank you.
Thank you, Helen. Thank you so much. I think that might be, if blind date ever comes back on, that might be my blind date introduction as well. Quite enjoyed that. Thank you, Helen. Yeah, so morning, everyone. So thank you so much for having me this morning to your meeting. So my name's Carrie, like Helen said. I'm Head of Medicines Management over at Knowsley and lead on AMR for Cheshire and Mersey. So next slide, please. Thank you. So the areas of focus that I was going to look at this morning, I've listed there. So we've got our performance dashboard, an area of focus on the new NHS performance and assessment framework dataset. Look at our Superbodies campaign, the importance of our hydration work, penicillin delabeling, target toolkit that Will's already touched on, some of the audits that we do out in primary care, the importance of World AMR Awareness Week, Pharmacy First, and then I've just listed our contacts at the end, which might be helpful when the slides are shared. Next slide, please. Thank you. So starting off with our dashboard. So our AMR agenda out in primary care and across the ICB is very data driven. So we use our dashboard a lot. It is updated monthly on those 5 measures that you can see there. So we've got antibiotics per star PU, Kefquins and co-amoxiclav, prescribing in children, prescribing of antibiotics for UTI, and then our 5-day prescribing of amoxicillin and doxycycline course lengths. We have the purpose of the data is in a way to increase the ownership at practice level of how that individual practice is performing for those 5 measures. We encourage ownership of prescribing by the individual prescribers, but it is a bit of a tricky data set to manipulate. So we are creating a bit of a guide to try and help people access their data a little bit easier. So next slide, please. So this is what it looks like when you land on the landing page for our business intelligence portal. And there's an email address on there, so datamanagement.bi@Cheshire and Merseyside, and there's also a little YouTube video of how you access the BI portal. So we can arrange access for our public health colleagues to access this data, so you can get the most up-to-date data in maybe a little bit more of a manageable way, because it is quite an easy read format. On the left-hand side, you'll see the homepage lists all the different areas. So if we scroll down far enough, one of them is prescribing, and then within prescribing, the AMR dashboard sits. Next slide, please. So this is what you will see when you land on the AMR metric dashboard. And as you can see, those 6 measures there that we look at with regards to our key focus areas in volume, restricted, course length, children prescribing in children, prescribing for UTI in the elderly are all listed there. That screenshot you can currently see is at a Cheshire and Mersey level. And where I've put the red arrows on the left-hand side, you can drill that information down for your place, your PCN, your practice, the selection of practices if you're interested in. And you can also change the data period as well. So you can have a proper look at the trend of how well whichever area you're looking at is performing for those areas. So the next slide, please. So I've just gone into a little bit of detail for the measures that we've got at a Cheshire and Mersey level. So for antibiotic items per star PU, so our total volume of antibiotic prescribing. So we are moving in the right direction at a Cheshire and Mersey level. We are still above target, the legacy target of 0.861, but we are moving in the right direction, which is great. And as it is a 12-month rolling figure, if that line did suddenly do a vertical drop, that would actually be quite worrying. So it's probably gradual is the right trend that we're looking for there, a bit more sustainable. Proportion of Kefquins and co-amoxiclav, so we sit well below the target of 10% there, which is great news, but we also recognise that there is still opportunity there across Cheshire and Merseyside because we still have quite a lot of antibiotics prescribed. So it's still an area of focus for us, even though we're below the 10%. Our amoxicillin prescribing, so this is our 5-day course length. So you can see we've had a gradual increase since the hard work started across Cheshire and Mersey. So we are on the up, and I think Cheshire and Mersey is one of the national kind of leaders on specifically amoxicillin 5-day prescribing, which is great news. Next slide, please. So these are the remaining measures that you can look at if you log on to the BIP and get access to that. So the first one there is around prescribing in children. This is just ages 0 to 4. So you can see that kind of seasonal prescribing there. We do, however, have a new measure around prescribing in children, but again, it's a useful narrative. And we use it across the ICB and at place to really identify practices that may be an outlier with prescribing in children and if they need some extra support around that. The middle one there is prescribing for commonly used antibiotics used to treat UTI. Again, very much linked with the hydration work, which is going to be discussed later. Our focus there is around obviously reducing patients experiencing UTI, and there's a correlation there with the number of antibiotics required being less, so the number of UTIs being less. It's been a real focus area for Cheshire and Mersey recently. And then the 5-day prescribing of doxycycline. So we haven't reached the lofty heights of the amoxicillin 80%, but we're at a steady 50% there. We probably started the doxycycline work a little bit later. So yeah, that is heartening to see that we're on the up there as well. Just a bit of a health warning around this data. So I only found out earlier this week that there is going to be a pause on the data. So we don't currently have August data available on the Business Intelligence portal. And when the data is re-released, it is no longer going to have the prescribing in children aged 0 to 4 and the prescribing of UTIs in over 70, but it will have the others. The prescribing in children ages 0 to 4, I think we're less bothered about because I'm going to cover that later on in some of the slides. But just to let you know, if you do gain access, there may be a bit of a data lag over the next few weeks, but it will rectify hopefully soon. Next slide, please. So yeah, antibiotic prescribing in children has been a real focus. So you can see the little graph on the left-hand side can show that general increase and a worrying trend of the percentage of children prescribed antibiotics. So we have a new data set to allow further understanding of our prescribing. Rather than 0 to 4, we've got 0 to 9, which is probably a bit more helpful. So next slide, please. So this is how Cheshire and Mersey perform on this data set currently. So we can drill down to place and practice level, which is really helpful. You can imagine the variation we see not only across Cheshire and Merseyside, but within our own places. So the target is to get to 27% or below. We currently sit at a Cheshire and Mersey level of 29.9, so we do acknowledge that we've got some work to do there, and we can identify our practices where we need to focus our efforts with there. I've also put the hyperlink on this slide, so when they're shared, people can have a little bit of a further look into this. Fairly new data, but yeah, it's really helpful, and we'll be using it to form our work plan going forward. Next slide, please. And then seamlessly on to more kind of focus work with our children. So Super Bodies is a campaign that we launched across Cheshire and Mersey last year. It's also currently out and about this year as well. And it's far reaching across the whole country. And I think the World Health Organization are interested in it now. So this campaign, as you can see, it's quite catchy. We focused on 3 main areas of ailments in children that they will attend or seek medical help with. The design was for parents and carers to have the most up-to-date info about managing common ailments. The focus was not to parent bash and not to say you're doing this wrong and you're doing that wrong. It was more about a supportive element. Alder Hay were a great collaborator with this piece of work. So the onus here was to find out when to stay at home, for example, and when to get help. So, for example, it was the carousels that sit behind each of these were along the lines of how to feel better at home was one of the titles, and when to visit your GP and when to call 111 or 999, which is just a helpful guide. I think I've just tried to pop in the link. I don't know if it'll work into the chat. That will just take you to, oh, thank you, Anthony, you've popped it in. Yeah, that takes you to the campaign. So yeah, a really catchy campaign. It's been received really well, great collaboration. So we're running it again this year, so if you see it, please feel free to share on your own Facebook pages or Instagram pages. And I'd just like to say as well, we've also got links on the information that Anthony shared to the Alder Hay Symptom Tracker, Healthier Together app and Pharmacy First. So Pharmacy First allows treatment of sore throat in ages 5 and over and earache in ages 1 to 17. So it's another kind of handy signpost as well. Next slide, please. Thank you. So hydration focus, which I think is going to be touched on much better than me a little bit later on, but I just wanted to give a bit of an overview because it was a great piece of work across Cheshire and Merseyside. So this slide summarises the approach. We had a hydration improvement practitioner that completed sessions in our pilot sites, which showed real positive improvements across Cheshire, well, across the pilot sites that we are now trying to replicate across the rest of Cheshire and Merseyside. Next slide, please. This was just the landing page of the Care Skills website, which is the legacy, I suppose, of that hydration work that we did. The staff turnover in care homes is huge, isn't it? So this is a very live conversation that we have with our care homes all the time. But it's a really easy to use platform. You can see on the right-hand side, we've linked, hydration links to not only reducing UTIs, but improved skin care and things like that, so widening the scope of the importance of hydration. So a really useful website for people to access. Next slide, please. Penicillin delabeling, which Will has already kind of touched on, but we are looking to this boiled down, unfortunately, to the lack of communication between the interfaces. So if a patient was delabeled of their penicillin allergy in secondary care, the letter would be sent to primary care, and sometimes it would be not actioned, which is just frustrating for everybody, isn't it? So we've created a Teams form for the secondary care providers. They fill the form in, it comes through, usually to me, and then we ensure that that communication is cascaded to the AMR lead at that place and that the patient's notes are updated appropriately. That's been a really quite an easy fix for that one, quite a helpful piece of work. Next slide, please. Target toolkit. So Will's already touched on that, and I'm so pleased to see those figures come through on the graphs because it's a real focus for us in Cheshire and Merseyside, and a tool that we use a lot and we find it really helpful. The only request we've put into Jill Demant is, could we please try and have some bite-sized sessions, because trying to get an hour with a clinician in the middle of the day or any part of their day is really tricky. So I've just listed the indications there, and I just wanted to mention that it's an ongoing focus for us in Cheshire and Merseyside. Next slide, please. So AMR audit. So audit continues to be a really important part of the work that we do. So I've just listed that we've all chosen across Cheshire and Merseyside one of the Pisces audits to complete. And then the second bullet point there around the work we did around prescribing of repeat antibiotics for recurrent UTIs was a huge piece of work that we did last year and possibly the year before as well. And we saw some great de-prescribing there and improved patient care. We've also recently had methenamine added to our formulary as a patient as a treatment choice for our patients, and we're cascading the importance of vaginal estrogen as well as an option for some patients around recurrent UTI treatment. So yeah, loads of work going on there. We've got a meeting next week to agree on our 26-27 audit, which is great. Next slide, please. Everyone's favourite week, World AMR Awareness Week, coincides with my anniversary, wedding anniversary, so double celebration. So we did a cascade of information across the whole of Cheshire and Mersey. I've done a little snippet bottom right there. We focused on prescribing in children with our Super Bodies campaign and sustainability, so around antibiotic amnesty, around everybody's dreaded cupboard in their kitchen that has a course of whatever left over that they share with their neighbours, so to try and encourage them to bring that back. So they were our key messages. And then our next slide, Pharmacy First. This is just to show that the concern that we were going to have an increase of antibiotics in our community hasn't actually happened. So you can see for the Northwest, when you compare 24 to 25 in 25, we've actually had a reduction in total antibiotics, which is great news. Was a concern that we had. And then the next slide. These are just the areas that are included in Pharmacy First for the consultation. And this is just to articulate that not every consultation ends in a supply. And sometimes it's just a consultation, and there aren't huge numbers of escalations. So again, another real positive of an initiative that's been introduced. And then the next slide, please. This is just the final slide, and this was just because across Cheshire and Merseyside, in each individual place, there is a lead for AMR. So if you want to reach out to those individual people in your place to find out what you can collaborate on, your own footprint, that would be great. The 3 next to my name is an error. There certainly aren't 3 of me. It's just a computer error, unfortunately. But they were just the emails that I thought might be handy for people to have. And that's it from me. I think my next one just invites some questions. So thank you all for listening. Hope you found it helpful.
Thanks, Carrie. That again was an action-packed presentation. Really, really interesting, and gives us a flavour of kind of life on the ground, as it were. So really good, and really helpful links back into Will's presentation as well, which kind of makes it more joined up, which was really nice to see. So we've got a couple of minutes before we take a break at 11, I think, to just see if there's any questions in the chat bar, and if Carrie and Will can be unmuted, and we'll just have a quick look at the Q&A in the chat. We've had a few through. Just let me quick. I'm just going to pick at random if that's all right. So a question for Will first, if I may, Will. So Lucie Hill has asked that you touched on AMR being a global public health issue, but wondered what actions AXA are taking to support a more collaborative global effort.
Yeah, thank you. It's an important question, and global and international collaboration is really a key, or one of the key foundations that's set out in the National Action Plan, and UKHSA are one of, as far as human health goes, one of the leads on that, officially being under DHSC. But things that we're doing in terms of human health, so we participate in the WHO, what's it called, the Global AMR and use surveillance system. So we share and contribute a lot of data to that system, which helps coordinate international efforts. We also, so I mentioned the SBAR report, which do please have a look at. So that's probably the most comprehensive annual report produced by any country in the world, and we're very transparent about our data. So sharing that is helpful, as well as the interventions that we're using to tackle antimicrobial resistance. And then also we do direct sort of support work with some countries. I wouldn't be able to list them all, but I know, for example, I was involved with a program where we were supporting Ghana with antimicrobial stewardship initiatives. So yeah, there's a whole range of activities that UKHSA are involved in, but some of the other international ones might be led by other bits of of the government or of government departments.
Fab, thanks, Will. It's a really helpful and comprehensive answer. I'm going to turn over to Carrie now, if that's all right, Carrie. We've had a question about how can the wider system strengthen and support ACB colleagues and the work being done around AMR?
Thank you, Helen. Yeah, another great question. And I feel like a lot of the work around AMR and a lot of the work that we do comes down to communication. So just general communication. There's some little bullet points I've written down here around communication to patients around self-care. So about having a harmonized approach. So for example, if you go to, regardless of which system or which practitioner you rock up to or who you go to advice to, you get the same advice each time. So like a single version of the truth, because it's quite complicated out there, isn't it? So I do think that combined effort around communication is just really important. As you can see from my presentation, we've got a lot of priority areas, and a lot of it comes down to there's patient behaviour, and then there's also prescriber behaviour and how they've always act. So I think my kind of key message, and my only answer I can come up to is just to help with the communication of those key messages out to our population, really. And which is why I think the Super Bodies campaign has been such a success, because it was really easy for the population to digest and understand. So working on future schemes like that and making them a bit more understandable, I think would help the agenda hugely, Helen.
Brilliant. Thank you, Carrie. That's a really helpful answer. Now, I've got a bit of a tricky one. I suspect that you won't have the answer to it, either of you, but it's a conversation I think that is a really interesting issue, and it's raised by Julia Rosser, our consultant in public health at Holton, and lead for health protection there. And Julia's asking, have we ever focused on identifying AMR-related deaths in the Child Death Overview Panel annual reports? It would explicitly identify preventable deaths in children locally and raise awareness in the system. So I have to say, I don't think I've ever seen AMR-related deaths in CDOC reports, but I don't know if Will or Carrie, you've got anything you can add into that.
Yeah, I've not seen it explicitly. Well, I've certainly not seen it as a theme. I mean, I've seen infection picked out previously, but it's been a while since I've been involved in anything to do with CDOC when I was a trainee. But you know, the numbers are small, thankfully. You know, nationally, we're not looking at large numbers of deaths from AMR infections in children, but we do, as I say, we do see them. So I would imagine there would be deaths in the Northwest. I've not actually counted up, but yeah, it's worth looking at.
I have to say, it sounds like a nice project for a specialty registrar to have a look at that and see what the extent and magnitude is around that, notwithstanding the emotional impact, of course. So, Julia, I hope that goes some way to helping. We've got a few more minutes, so I'm going to take chair's prerogative, if I may, and just ask you both about penicillin delabeling. Now, that's a new one on me. I don't know what it means. And I don't know what it does. So in a nutshell, can you help me?
I mean, Carrie might want to lead on it, but sorry, I mentioned it in my presentation, but only in passing. Sorry. So, and you'll have to correct me on the numbers, Carrie. You'll be better at it. But I think between 5 and 6% of patients nationally report penicillin allergy, but around 90% of those are not actually genuinely allergic. It's things that have been labelled, we call it spurious allergy labels, that from historical rashes in childhood that have probably coincided with them taking the antibiotic medicine that's been prescribed, and they're not allergic rashes, they're just, or any allergic side effects, they're just things that have gone on.
So does the delabeling then kind of mark the transition where someone who's been traditionally thought to be allergic to penicillin is now not allergic to penicillin, and so you take that label off their record? Is it as simple as that?
In theory, it's not as simple. It's not as simple as that, as Carrie explained. But and there's a benefit to doing it, which I'll let Carrie explain. But if we can not have people labelled inaccurately as being allergic to penicillin, there are lots of benefits. But yeah, Carrie, please go on. You're the expert.
Thank you. Well, yeah. So there's been some national noise about this as well, but it's taken a little while to get off the ground, unfortunately, to see how we can action it further, which is why across Cheshire and Mersey we've just agreed this kind of bespoke approach for now. We had some local trusts that were looking to actively challenge penicillin allergies where they felt they weren't true allergies, like Will said, and removing the allergy status from that patient so that they had a wider choice of antibiotics should they need that treatment going forward. I think there was some studies done that the AMR and having a penicillin allergy labelled increased the risk of developing an AMR in that patient, basically. So the more patients that we remove the inappropriate allergy and penicillin allergy from, then the better for the system, because there's all sorts of it's quite emotive, isn't it? I don't know if you've come across someone, who I do have a penicillin allergy, and then when we've talked to them about it, oh well, I felt a bit sick, or oh well, I had a little rash, or oh, it was when I was a baby. So it's some of those conversations that we're trying to just eke out so we can get a true picture of how many actual patients with a penicillin allergy we have.
So final question then, is that change in a person's diagnostic label just done by conversation, or do you actually test it out, like with adrenaline sitting next to you?
Yeah. So in our sites that we're working with, Helen, in secondary care, so Alder Hey have a risk stratify approach of it. So they will have and exactly that, they'll do the challenge in hospital. With the patient will come in, they'll have the challenge, and then they'll be sat there and monitored and ensured that there is definitely no allergy before that communication is sent out to the primary care, so that we can take it off their system out in primary care as well. But there are different levels of severeness of the allergy depending on how the allergy is challenged and removed.
And just,
Really helpful. Sorry, Will.
For those that so I realised the risk of sort of sitting in an echo chamber. So we talk about this all the time, and just I realise it's multi-agency, meeting. So penicillins are used as a first-line agent for many common infections. So that an inaccurate label can have significant clinical consequences, because patients are then, when they are labelled as allergic inaccurately, or otherwise they're prescribed a broader spectrum, second line agent, which might include other things like macrolides or whatever it is, fluoroquinolones, whatever, and which increases, probably worsens outcomes, increases the risk of adverse events, and even things like increases the risk for developing C. difficile or MRSA or other antimicrobial resistance. So that's what we're trying to address by the delabeling campaign.
It's really interesting. I just hadn't heard about it before. So we've got 2 minutes left, and Mandy from the Health Innovation Northwest Coast has popped into the question and answer bit about how the Innovation Northwest Coast team are working on a number of pathway and diagnostic projects. Mandy, if you want to come in, you're welcome, but you've got 2 minutes, and I will cut you short, I'm afraid, because everyone's gasping for a coffee now.
If colleagues want to follow up, they can contact me separately rather than hog the agenda today, but there is quite a lot happening. We're working with a couple of colleagues, academic colleagues, on a number of projects to explore how useful diagnostics are in helping to improve the target antibiotic use. So just get in touch, basically.
Brilliant, thanks, Mandy. If you want to just put your contact details in the chat bar for people, that would probably help. Final comment from Derek.
Just to say, Mandy might have mentioned things that I might even mention as well in the talk I'm giving next. So I'll highlight some of the work that Mandy's even done. So nice to see you, Mandy.
Brilliant, thank you. So just really to say thank you to Will and thank you to Carrie for some really fascinating comments, presentations this morning. A lot of food for thought in there. Okay, everybody, welcome back. I hope you've had time to have a stretch and a walk around and get yourself a brew. We'll go straight into the next part of the programme, if that's okay. So I'd like to welcome Dr. Derek Cocker, who's an academic clinical lecturer in infectious diseases and global health. Derek works with the David Price Evans Group, and his research takes a One Health approach to evaluating the drivers of antimicrobial resistance across health systems and communities, with a focus on developing strategies that protect patient pathways and reinforce healthcare systems. So, Derek, over to you. You've got till about 11:30, if that's okay.
That's fabulous. Thanks, Helen. So thanks again. Yes, I'm Derek. I'm an infectious doctor. I work at the Royal in Liverpool, and I'm also a lecturer at the University of Liverpool. I work with a selection of other international groups, CamoNet, which is a consortium across 13 countries in the Global South, and the Fleming Fund, which is a UK-funded AMR network, again in the Global South. But I won't be talking about global work today. I'll be thinking about more of the local work that we're doing. And we work with what's called the Fleming Initiative, which is a consortium looking to optimise antimicrobial usage in the UK. So I'll talk about protecting pathways from antimicrobial resistance using some innovative approaches. Thank you. Next slide. It'll be a bit of whistle-stop tour, so I'll go through this at lightning speed, but the slides are all here for you for reference at the end, okay? So I'll talk through how healthcare itself acts as a driver, reservoir, and amplifier of antimicrobial resistance. I'll talk about the importance of protecting patient pathways and the importance of protecting how that protects healthcare itself. which I think this group will be very acutely aware of. And then I'll think about going through some of the research highlights from the University of Liverpool collaborators and myself and the networks we work with around areas, particularly around vaccination and AMR and diagnostics, both for acute respiratory infections and sepsis. Next slide. So this is an overview of how healthcare acts as a driver of infection in AMR. And on the left, you have these people who are the public who either have an infection, and the infection could be, for example, a viral infection like flu or COVID, or equally, it could be a bacterial infection or colonization, for example, with something like MRSA or CPE or ESBL. Now, people come into healthcare settings, and that can be GP practices, pharmacists, or often hospitals. And in these environments, they are more exposed to the pressures and selections by having more chance of being given an antibiotic, either appropriately or inappropriately. Alongside that, they come into contact with patients, staff, and visitors, so individuals, and shared environments. And all of these different areas can provide a risk. If we don't control and protect these areas within healthcare settings, both the delivery of antimicrobials and the protection from the environment within those settings, then actually it can lead to healthcare itself pumping out at the end of it more people who have the infection or the resistance than at the start. So think about what Will mentioned about HEIAs, so COVID, flu. So many amounts of COVID and flu are actually hospital acquired. If you think about antibiotic resistance, again, it's about people who are given an antibiotic, but then they're actually colonized with a resistance organism when they're discharged into the community. In the community, then it interacts with other members, whether in their households or long-term care facilities, particularly vulnerable individuals. And these cycles repeat itself. We don't go to healthcare once in our lifetime, many, many times. And the important thing here is that the most vulnerable attend more often, and that's really key. So they're the ones that need protecting the most. Next slide, please. So what are the risks within patient pathways? Well, pathways are by their nature complicated. And really what I want to highlight here is that we actually in the NHS create quite complex pathways and environments that expose the most vulnerable to the greatest risks and highest levels of antibiotic pressures. An example I might give you is oncology patients or people with chemotherapy, so cancer patients. These are often immunosuppressed. They attend hospitals, they attend sort of chemotherapy units, they attend GP practices, and they're higher chance of having colonization with resistance and higher chance of getting antibiotics. So these are vulnerable populations, and yet we still streamline them all together, we cohort them together, we act to them together. So sometimes here, the difficulty is around the problem we have with our language and siloing. And I think this group is really key for this because, in a sense, with AMR, the strict divide between primary care, secondary care, inpatient care, outpatient care is really, really unhelpful. So what we really need is like a whole health economy approach to prevention infection that spans across these boundaries. Otherwise, we can't mitigate AMR. And so what I want to highlight here is that protecting patients is super important, but actually protecting healthcare is our ultimate goal, and we need to adjust our outcomes to capture this. And that's really poorly done in research, and it's, I would say, not so adequately done even within our national metrics. So trying to put funding into, for example, primary care to benefit secondary care is really hard. So we need to get better at this. Next slide, please. A case example I'm going to give to you is seasonal influenza winter pressures. We know this very well. If you have flu or COVID, then the chances are you're going to potentially have increased seasons where there's reduced operations, increased ICU admissions, reduced patient flow and bed pressures. In the UK in 24, there was increased occupancy rates, increased A&E diverts, and outcomes from a number of bodies show that actually, despite the fact that we see this flu every year, we're not so well prepared in the winter, and post-pandemic, we're still performing a lot worse than we ever were. And so interrupting this kind of pathway at an earlier stage is really, really key. Next slide, please. So what I want to say is on that patient journey, this sort of systematic overview from before is about the measures in which we can sort of prevent both infections from being occurred or ultimately antibiotics being prescribed at both the community and healthcare level. Next slide. So there are plenty of opportunities to protect patients in healthcare. If you're interested, I'll put one of the Nature papers in the group later, which go through all of these different areas in much greater detail. But just to say that there's a high amount of options that we have in our arsenal. It's about getting the right ones delivered in the right way. So vaccinations and immunotherapies to protect patients and staff, improved diagnostics and antimicrobial optimization associations, infection prevention control interventions and innovations, both within healthcare settings and in communities, thinking about changing those pathways and the optimization of healthcare in itself is quite a novel approach to change. So trying to change the pathway structures, thinking about our importance of earlier surveillance and using diagnostics, for example, in our surveillance strategies, both in communities, hospital environments, and even things like wastewater. And then, of course, we can't say research opportunities without thinking about AI and data linkage. The problems, obviously, with these are felt with the fact that we're still in an early phase of this, and actually a lot of this involves in health technology infrastructure to be existing to be able to do it. But the opportunities here are very, very broad. Next slide, please. So what I want to focus on really is that we don't necessarily need to invent the wheel. It's not all about a scientist saying, I've got a really new idea, you must do this. It's about doing the things we know better or in a more simple way. So we have vaccines that work. Prove how well vaccines work for AMR, target at-risk groups, focus on marginalised populations and most deprived, most at-risk individuals. Diagnostics, well, we already have diagnostics. Maybe think about citing them earlier in patient management, maybe into primary care, decentralize the diagnostic pathways, patients doing their own diagnostics, for example. Thinking about having information earlier on to act on to optimize antimicrobial prescribing and reduce antimicrobial resistance in this way. Think about simple messaging of hand hygiene and adherence. I think there was a talk earlier about, for example, fluid in children, for example, simple messaging, communication design about things we know work. Those pathway designs, and Mandy's on the call, so I'm actually going to highlight test and treat because it was done in the Northwest as an example here for COVID and flu in the winter and reduction in prescribing. And then obviously some new wheels are going to be needed, and AI is definitely one of those, but we'll leave that one for now. And next slide, please. So I'm going to talk through how vaccines interact with AMR and some work that's been done in the Northwest through University of Liverpool. So next slide. Thank you. This is, if you're interested, maybe come back to. This is more of a systematic overview of how vaccines and sort of protective factors and monoclonals actually protect individuals and protect pathways and healthcare itself. Ultimately, we can understand that if you reduce your chance of having an infection, you reduce your chance of being prescribed an antibiotic, but you also reduce your chance of giving someone else an infection and that person requiring an antibiotic. So there's a real downstream impact that's massive from the impact of vaccinations. And globally, there's huge evidence, for example, on rotavirus, on typhoid vaccines, as being some of the most powerful AMR interventions that exist. But for example, COVID flu are the things that we're looking into now. Next slide. So Prof. Neil French and Dan Hungerford did some great work looking at influenza vaccines and antimicrobial prescribing. So a lot of the research I'm going to give now is based from their data. So thinking about how it changes prescribing in the UK population, including the Northwest. Next slide, please. So there was a CPRD, sorry, that's a clinical practice research database, I think, which is an online resource which includes a lot of primary care data, about 14% of the population that you can interrogate. And they did this by doing a sort of self-controlled cohort study, looking at individuals who were vaccinated versus unvaccinated in an elderly population, so above 65, for flu, and thinking about whether or not it reduced prescribing for respiratory tract infections. So they didn't use people that had always had a vaccine or those that had never had a vaccine, because they're very different types of people, but people that had them intermittently. And it was controlled, as you can see here on the bottom, by those who had it that season versus didn't have it that season. Next slide. So what do they show on this modelling? And this is so about 42,000 individuals across several flu seasons with a median age of 75 and about 4 vaccines on average. Looking at the IRR, which is the incidence rate ratio, which you can see for the sort of the triangle one is respiratory tract infections, and for the circle is all infections. And the difference between the two here is in the vaccination around peak flu season, and actually the IRR difference there is between 0.96 to 0.91 for respiratory tract infections, showing a difference or a decrease in prescribing associated. For the blue dot, much less so. So next slide. What does that mean? Well, it means that actually flu vaccines reduce prescribing for respiratory tract infections by about 10% during flu activity season. In terms of their impact on overall prescribing, it's a bit more complicated. Happy to talk about that, but really we don't necessarily know. We certainly know it's good for respiratory tract infections. Whether or not it has an overall benefit or not, the jury's still out. Next slide, please. So let's think about diagnostics. So this is the last one I'll talk through as examples. So how can we think about diagnostics and pathway redesigns and the improvements that exist in those? So next slide. So there's another study, again, Neil French was one of the PIs on this, so thanks to Neil for this. And it's called Pronto, which is procalcitonin. That's a host response marker. It's like CRP on a bit, it's a bit of a different version of that. And News, which is a clinical tool system looking at optimizing antibiotics in the emergency department for sepsis. So basically, it's about using point of care test in emergency departments and see if it changes IV to oral prescriptions. It was a multi-centre parallel armed individually randomised trial across England and Wales, including the Northwest, and about 22 emergency departments. Next slide. Let's go through this very briefly. There was a two-arm standard of care and intervention arm. There was two endpoints. One is about the antibiotic prescribing endpoint, which is about reduction of IV anti-initiation in patients with suspected sepsis. And the second was sort of a safety outcome, which is about mortality and does it basically impact on mortality. So we want to know that what we're doing is safe. Next slide. They randomized 7,000 individuals and 2,700 individuals in the control and intervention arm. I think we can go to the next slide. So what were the results? Well, interestingly, for antibiotic initiation, you can see on the left, which is the PCT, Kaplan-Meier graph, actually didn't change prescribing. So using a point of care test in this setting didn't necessarily change the antibiotic prescribing. So it's important to do these type of trials to understand why that's the case. However, next slide, of interest, despite the fact there wasn't antimicrobial prescribing, there was actually a mortality improvement by having a diagnostic. So 17% reduction in mortality by those that were diagnosed, which is a very complicated thing to unpack and highlights that this research is still not necessarily in its infancy, but it's still ongoing. And we need to think about diagnostic research as something that we need to do a lot more of, because we need to understand and unpack these kind of results where mortality may be benefit, but antimicrobial prescribing may change. Next slide. That's basically what I've just said. There's lots of reasons as well why this trial may have not showed an antimicrobial prescribing difference, but there may have actually been one. Part of that is to do with sort of trial effects associated with pre-trial assumptions of prescribing. And truth be told, when people are under trials, people prescribe a little bit less antibiotics, for good or for bad. So this is a problem that we often have in research, particularly around RCTs. And I can talk about some other RCTs that are not done through the University of Liverpool a bit later, maybe around point of care that were done through Oxford and Bristol that are very interesting. Next slide. So how about in the Northwest and thinking about this? So we're really keen on doing some more work on decentralized diagnostics for acute respiratory tract infections using point of care testing in GP practices, acute ARI hubs when they exist, and urgent care centres, and looking about whether it protects the individual and also those downstream effects of healthcare protection as well. Next slide. So in terms of that, Will's already touched on this, but just to re-go over it, in terms of ARI burden, so acute respiratory tract infection burden, it's the most common in the winter, as we can imagine. It provides huge amounts of healthcare pressures. At the Royal, for example, the amount of people that are on corridor care in flu season is excessive. 80% of the antibiotics are prescribed in the community, and for respiratory tract infections, it's 50% of people that go to a GP are more likely to be prescribed an antibiotic. And that data is probably a little bit lower now. That is slightly old data, and it does vary by practice and it does vary by season. But in actual fact, it's still around about 43%. We did an analysis of London data across about 5 million data points recently and showed that that number was actually about 43%. So it's still really high. And it's often because clinical judgment is used, which is not wrong. I'm a clinician and I do use my judgment every day and I'm pleased to have it. But sometimes it's being armed with data to maybe make choices and changes in a different way and feel empowered to make those choices. And that's where diagnostics come in, but also where pathways come in. It's about trying to not just give a diagnostic, but also maybe give it with some information, give it with an algorithm, and give it with some sort of educational material and communications around how you might want to interpret the test and deliver the test results to a patient. So there are lots of benefits for this. Next slide. In terms of where you can site these areas, you can think about GP practices, ARI hubs and diagnostic centres. There are a plethora of options, biomarkers such as CRP, procalcitonin and various other host response markers, including bacterial versus viral tests. There are pathogen-based tests, so viral or fungal tests, and there's combination approaches. So there's lots of options that we can consider. Next step, next slide. But this is Mandy's actual work, so glad to have her on here. But it's not just about implementing a test, it can also be changing pathways. So this is work that the health innovation team and Mandy did, looking at, again, in the Northwest, of what's called a test and treat pathway, which is where you basically identify a case, you give them a test, and then you can then stream them into being seen or not, and having treatment pathways or not. And the key from this work is actually that working with local practitioners and stakeholders is super key. Actually, if you want to make changes, you need to engage the GPs, the practices, and make sure it works for them. That's what I really want to highlight. So simplified algorithms that potentially could target vulnerable at-risk groups could reduce costs, could reduce antimicrobial prescription, and can certainly reduce in-person consultations, which is of benefit to everyone, especially at winter. So pathway change is one way of doing this, but also it's about the right test for the right condition in the right place, and we definitely need more research into those kind of streamlines, and that's where we're trying to do more research now. So next point, next slide. And as I said already, and just to reiterate the message, it's really not just about reducing those antibiotics. It's about thinking around reducing optimizing antiviral prescriptions, because we know that we can then, if we give people a diagnosis and you've got flu, well, actually, we've got Tamiflu. If we've got COVID, we've got some COVID treatments, and that can potentially reduce your transmissibility to other people. So it's going to improve your treatment, and it's going to potentially improve the treatment of others as well, and the chance of other people having infection. And it's trying to model these system-wide effects that we're really keen on doing. And thinking about those system care effects, the one that we're particularly interested in is healthcare utilisation, particularly in the stretched NHS services. What's key is, can we reduce attendances in primary care? Can we reduce hospital admissions? Can we reduce referrals, ITU admissions? Can we improve the economics of the system and the functionality of the system? At the same time, we do know that diagnostics actually have a lot of patient satisfaction, and sometimes build trust, which is what we need in a healthcare system. We shouldn't necessarily have to pay for it with a diagnostic, but nevertheless, it can be something that's of real benefit. And thinking about trying to use these things for broader aims, such as return to work and school attendance.
2
Next
minutes,
slide.
Derek.
I'm very close, thank you. So we need to think about this again as patient population and system-wide levels. And again, we need to be better at capturing these outcomes, thinking about it in our modelling and analysis, because if we're going to change what the government choose to do and fund, we're going to need to provide evidence that's not just at the level of the individual, but at the level of the health system. Next slide. So my 2 pence on AI and diagnostic integration with electronic healthcare records is that it's going to be a really exciting place to be in. It's a very new place to be in. So let's work together on making it work best for everyone. So there are very good options, and there's some really good papers here. Like one of them is mine, I won't lie, but most of them. So Tim is really great. Tim Rawson, and he works in London. He's a colleague like me. He does a lot of work on clinical decision support systems for prescribing practices, which is like using all the data in the electronic healthcare records and providing an AI-based algorithm to say this was what you should potentially consider doing. And they do a lot of work on prescribers for these types of systems and show that they can be trusted to some extent, and they do work. It's about the fidelity of them and the fact that they only work to within a certain margin of error, and we always need clinical judgment, and we always need to use them as guidelines and to support decisions, and not decisive yes/nos. Using electronic healthcare record can be a really clever way of thinking about identifying our local pathogens in epidemiology, so using the diagnostic data for surveillance, for example, helping to refine support outbreak analysis control. So you're going to have a bit of an earlier peak in understanding your outbreaks if there's more diagnostic data floating around. We can then think about targeting IBC inventions and secondary care pathways. We can think about early warning predictions of risk forecasting using these kind of tools. And we've done some work on this. And again, thinking about how we can be more agile in the winter seasons. Despite the fact that we get flu every year, we're not always well prepared. So healthcare resilience is really key. And that's one of the messages that the innovations of AMR can actually just impact as a whole, not just an individual. Next slide, and I think it's my last one. So what does this all mean? Well, hopefully I persuaded you that in terms of AMR, HAAs, infection, that protecting patient pathways from them in turn enhances resilience of healthcare, that there are lots of opportunities for innovation that we could work towards, and pragmatic ways, particularly around redesigning pathways, thinking about innovations around diagnostic integration and vaccine uptake, thinking about that digital integration optimization that can occur, and again working towards that, particularly with the public, because we want to make sure that everything is on board with what they think is right. But the key to all of this research is that it needs to span across healthcare boundaries. So it needs to be primary care, secondary care, all care, take a whole healthcare economy approach. Okay, thank you very much.
Brilliant. Thank you, Derek. And I feel like I've rushed you. There's a lot in there, and apologies for rushing you, but a really, really fascinating presentation and lots of food for thought in there as well. We'll come back to questions at the end after Lucie's session, if that's okay. So now I'd like to introduce Lucie George, who's from Cheshire West and Chester Council, part of my team, I'm proud to say. Lucie's a health protection specialist with 30 years of local government experience in environmental and public health. She's got a strong background in food and health and safety. We seconded Lucie into the COVID-19 outbreak team at Public Health England, now UXA. On a return to local government, she led the COVID-19 health protection response before coming into public health full-time at Cheshire West and Chester. So from my point of view, we're absolutely blessed having Lucie in the team. Lucie thrives on working in partnership across health and care systems to drive meaningful change in practice. Current projects include flu vaccination provision, delivery of supervised toothbrushing in early years settings, and leading on the delivery of hydration awareness training in Cheshire West. Her collaborative approach, grounded in evidence and prevention, supports sustainable improvements in population health and service delivery. So, Lucie, you're going to talk to us about maximising local interventions for minimising antimicrobial resistance. So over to you. You've got till about 1:45.
Okay, great. Thank you, Helen. And thank you for having me here today. And yeah, what brilliant speakers to follow on after. Really interesting stuff there. So slightly different approach from me. I'm going to give you a bit of a practical example really of how work that Cheshire West and Chester and local authority intervention has been undertaken to minimise antimicrobial resistance. Next slide, please. So just going to talk to you a little bit about the background. So why we're doing the hydration training, which probably is slightly obvious having listened to everybody else so far. We're going to just look at a bit of an overview of the content of the training that we provided, who attended, some evaluation of that training and further opportunities that we've got as a result of the training. Next slide, please. So to start off, just for background really, the Cheshire and Merseyside IPC and AMR group identified 5 priority areas in 24-25. These priority areas, one of which included a hydration pilot. But just for completeness, the other 4 priorities included improving reporting for healthcare associated infections and gram-negative bloodstream infections to deliver improvements. Also included implementing the 5-year National Action Plan to optimise the use of antimicrobials, which was covering reducing prescribing lengths, which has already been mentioned by Carrie. Promoting vaccination uptake was a priority. Again, we've already heard about that and certainly in Derek's talk as well, I think in Carrie's, as a key element. And also the other priority was public media campaigns, and we've heard about that from Carrie's talk as well about the super bodies. So that's just an overview of those priorities, but hydration was one of those. So we know that dehydration is associated with an increased risk of UTIs, urinary tract infections, falls and pressure ulcers, and a number of other things, but they're some of the key ones. And when we looked at the ICB data from April 23 to November 24, we could see from our own data for care homes in Cheshire West and Cheshire East that UTIs were frequently featuring there in the top 5 reasons for admission to hospital. And as has just been mentioned by Derek, admission avoidance is an ICB priority. It's everybody's priority. If we can avoid those admissions, we can see the knock-on, hopefully, improvement in the, you know, the AMR issues. So if we can avoid going into hospital, we can avoid a lot of issues. So really important sort of factors there. So in order to sort of put this together, we just worked with colleagues at the IC. Oh, just go back a slide for me, please. So in order to sort of put this together, we worked with the ICB, Cheshire East Public Health and the IPC team, looked at what we could do across Cheshire to address the hydration issues. And the ICB colleagues produced a hydration project plan. And there were a number of features in that, but two of the key things were for hydration awareness sessions to be held for care staff, and also the ICB to lead on some master classes, which we'll cover a little bit later. And just to note that previously across Cheshire West and Cheshire East, we had already run some hydration awareness sessions. So we had that kind of in place, really. So as far as the background goes, we've got some really, really strong evidence there to show why we're going to do hydration training and the sort of form that hydration training will take. Really fits in nicely with the regional and national priorities. So next slide, please. So a little bit about the training content. I've got to say at the first beginning, the hydration presentation was originally developed not by me. It was by Emily Kindred-Paxton from Cheshire East Council in conjunction with the CWP IPC team. So they produced the original presentation, which we then sort of reviewed and relaunched as part of this Cheshire-wide hydration project. So thank you very much, Emily. So key topics of the training. Just to run through some of the things that we really wanted to get across. So how thirst changes with age, dehydration, signs and consequences was a really big one, really tried to sort of push that. Importance of hydration, why our bodies need and lose water. Some of these things sound quite obvious, and the training was accessible to all level, just awareness training, but it was quite good to sort of just run through this with everybody, just to remind everybody. Prevention in practice. This was quite an important element, and looking at the reducing the need for and awareness of antibiotic usage. So that was quite a key part. We also looked at hydration at end of life, because there's some very specific requirements for that, which aren't what we would normally be pushing on a hydration seminar for the general population. And also practical ways to increase fluid uptake, and also looking at individual needs and preferences. Now, the training that we provided was arranged all on Teams. They were around 1 hour, just over 1 hour long, and we held them at 2 p.m. and it worked really well with the care workers that we were wanting to try and engage with. The training was also quite interactive. So we used some polls to ask things like percentage of water storage in muscles of people and how that changes with age. We asked questions about how the sense of thirst changes with age as well, and use word clouds. So it's very interactive, and it was brilliant to see that in all the sessions we did get really good interaction from participants throughout. And we also included a lot of practical tips, and we'll see some of those in the next couple of slides, about how to improve and encourage hydration. And during the training sessions, we had the IPC team available on the training where possible, so that any clinical questions could be answered, because I'm not clinical, so they have that support there. And if they weren't available, then we could take questions away. And as you can see from the slide there, we provided a certificate of attendance, which actually went down really well with everybody. And in order to do that, we just got people to type their name, employer, and email address into the Teams chat. So it's all done very simply, and tried to keep it as simple as possible. Next slide, please. Sorry, there we go. Brilliant. So this is just an example of the presentation, just to give you a bit of a taste for it and some of the practical elements of it. So here we have, it's a guide really to Timothy's requirements, but things I want to just point out to you really is how we push a person-centered approach to hydration. For example, we talk about cup preferences on this slide. If somebody that's being cared for has the wrong cup, the wrong mug, and they aren't able to drink properly with what they're being given, it's going to have a massive effect on hydration. So really, like, simple suggestions and things to think about. So cup preferences, also what you're giving somebody to drink. If we've got it documented what people prefer to drink, they're more likely to drink it, and also if assistance needed. So this is just a bit of a taster of some of the things that we were putting out to the carers to make them think about how they could increase that hydration intake in the people that they're caring for. So next slide, please. And here, just another example of foods that can increase and contribute valuable fluids to help keep people hydrated. So plenty of practical content included in the training. We also included links to training resources, YouTube videos, also a urine colour chart so that we could clearly see what urine is good, and obviously when we need to be concerned if it goes darker, and lots of other helpful sort of practical tips like that. So it's very accessible to all, nothing groundbreaking, quite simple, but just really good reminder. Next slide, please. Okay, so we just a little think about the attendees. So between October 24 and April 25, we held 10 online hydration sessions. So this was across presented by Cheshire East and Cheshire West. And it was open to dom care, learning disability staff, nursing and residential care. We trained 326 people and we covered 83 settings. They were represented by the people that attended. So really good uptake. Very pleased with it. We did use our local authority quality colleagues a lot to encourage attendance by pushing out the comms through care provider forums, and we also encouraged the quality team staff to attend so that when they were going out to some of the settings, they knew what we were pushing and they knew the information so they could further support the training that we were giving out. And after the training, we shared data on who attended, numbers, and which settings attended with our local authority quality colleagues and the ICB colleagues, so they could use that data to provide intelligence for future actions and visits. Next slide, please. So after the training, we did put some surveys out. Now, unfortunately, the survey wasn't available at the start of the training, so we haven't got a great deal of responses. We've only got 24. Appreciate that's a small number, but just looking at those 24, everybody who responded agreed or strongly agreed they enjoyed the training, that they learnt something new and were going to make changes, and that they would recommend the training to other people. So that was really good to hear. We also asked people to type in something that they'd learnt during the training, and as you can see there, it's a little small, but 16 out of 24 said they'd learnt about the signs, effects of dehydration and the importance of hydration, and 14 said they'd learnt new ways to increase fluid uptake. So that was really good to get that information back. And we would look at, for future sessions, trying to increase that response rate by probably getting them to do the survey in the sessions, so where we could improve that. Next slide, please. So further opportunities. I mentioned earlier that ICB have held some masterclasses, which were half-day sessions in person with dietetics, speech and language therapy, tissue viability, continence, and the IPC teams in attendance, and they've gone down really well. There will be more to come of those. So 1 half-day class in Cheshire East and 3 in the West. Another opportunity is that ICB quality teams are devising a schedule to visit care homes with nursing beds to review the impact of the masterclasses. Another point is we are still looking, really. We don't have the hospital admission data at the moment to see the impact of this hydration awareness training, but hopefully in time we will get some further data so we can have a little look at that. And then finally, following the success of the training and how we ran the training, the idea is to plan further hydration sessions in the new year. And in Cheshire East, they've already started in the same format, providing AMR awareness training. I think the last two were last week or the first two were last week or the week before. And we're going to be looking to present that across Cheshire East and Cheshire West in the new year using the same format because it went down so well. Next slide, please. And it's just my last slide. So really, I just wanted to push out to the local authorities there that the online training sessions were really popular. They were very accessible. They were really well attended, very easy to set up and run on Teams, and minimal cost. It's just a little bit of staff time in the setup and also to produce the certificates. And the main message, I think, would be we're more than happy. I've spoken to Emily, and we're more than happy to share this training material with any of our partners, any of our local authorities, for you to have a look. It's there, it's very easy, and I think it's just a brilliant way to try and push those communication messages that Carrie mentioned as well, about how important communication is in relation to AMR, and to get that information out and to encourage people to think a little bit more about hydration, which hopefully should have a positive impact on dealing with AMR and hospital admissions. So thank you very much.
Well, thanks, Lucy. That was, again, another informative presentation and something close to my heart, of course. So brilliant stuff. We've just got time for 2 questions before we move on to the next section of the agenda. So I'm just looking in the chat, the questions, sorry, and I've got one for Derek, which is, Derek, you referenced the benefits of utilising point of care testing. Were there any learnings from having to implement training and get point of care testing rolled out across out of hospital settings?
Well, I might, if she wants, I might let Mandy talk about the example of test and treat locally. But in terms of UK-based, there's been a good few trials that have existed of point of care testing, both in terms of Bristol, Oxford, and Southampton predominantly. And actually, the majority of the implementation aspects focused again on individuals often not being the device of these pathways not necessarily being delivered with practitioners such as GPs being part of that process, and that realizing that every practice is different and every practice has a different process was really key. So what people often wanted was to have supportive interventions to go alongside them, and that would often be either short educational materials or even access to, for example, even the UKHSA target-based and RCO Royal College of Physician guidance, alongside communications awareness, to trying to get GPs to be able to communicate the test better. That's what a lot of the data is suggesting, is that actually what's having most companies make a test because they think it can tell you if you've got flu, but that doesn't necessarily mean it's going to change, as I already highlighted, behaviour. So behavioural work is really, really key, because it's about what is the level of risk that an individual is going to need to overcome to change their mind, particularly when they have been doing for 20 years something that's worked very well. So again, it's about thinking around those supplementary interventions that are needed. Thanks.
Brilliant. Thanks, Derek. And then there's a question for Lucy in the chat around any key learnings from running the pilot that might help shape future interventions.
Should I talk about that, Derek?
Well, I'm just, in the interest of time, Mandy, I'm moving on to the next question. Sorry, yeah. I'm just conscious that we've still got breakout rooms to do. So I think for the purposes of the audience, we've probably got enough information. Thank you so much. So Lucy, do you want me to repeat that question?
I think it was key learning. So
yeah, from the
if
pilot.
I'm right. So I think for the pilot, is definitely engaging with those quality teams really early on to get the spread as wide as possible, so we can get maximum people attending, as far as actually getting people there. And I think there will be more key learning, hopefully, when we get the feedback from the site visits that are going to be done from the ICB. So when we go in and have a look and see in practice, and perhaps from our quality teams when they've been going visiting, to see in practice have things actually changed. So I think potentially for another survey or follow follow-up might be quite useful to try and maximise those learnings. But I think engagement with as many people as possible to spread that net wide, and so we can get the training as wide as possible.
Brilliant, thanks Lucy. Really helpful responses, and again Mandy, apologies for cutting you short there. So I'm going to now introduce the breakout sessions. We are going to be randomly placed into breakout rooms, and one colleague in the room will capture key discussion points and put into the breakout room chat, and then we'll collect those later. So there's one question that we're asking you to consider, and that's, what are the big opportunities for better collaborative working? We are going to move on to our favourite thing, our Mentimeter. The details will be on the slide, and we'll put the link into the chat. And the question we are asking this time is, what's the one thing you're going to go away and do? So just a couple of minutes quickly to fill in that, if that's okay. If we haven't answered any of your questions today, or if there's anything burning you want to bring up post-event, then please do just drop us a line. I believe there's some stuff on the Menti, so I'm just swapping screens, bear with me, and I can't read it because it's so small on my laptop. So look at opportunities around penicillin delabeling. I couldn't agree more, because that was a new one on me, and as a registered nurse I should know about it, and I don't, but I'm public health, so I don't do much around drugs anymore, not that kind anyway. Considering more with care homes around education, I think that's an ongoing issue, isn't it? Going to work across sectors, including with CHAMPS. It's an open door as far as CHAMPS is concerned. Come and join us, be with us, go on the journey with us, and plenty of other comments there as well that we won't go into now, but we will use when we send the notes and the presentations round. So any unanswered questions will be responded to. And as I say, if you want to stay up to date with the activity, whether it's health protection or broader, stay in touch with the collaborative, sign up to the newsletter, the chat, the very beginning of the chat, we put that link in. The more the merrier. We are a friendly public health family, as some of you already know. So please do join up and keep in touch. And then finally, just again, huge thanks to everyone, attendees, but particularly speakers. And if you wouldn't mind just completing the feedback survey, which we'll email to you after the event, we'd be really, really grateful. So conscious of time, it's 12:10, which is our finish time, so I won't go on anymore, but just huge thank you, everybody, and have a great weekend when you get to it. Thank you.